So this particular webinar, for some, this may be, um, you know, a little basic, but we want to make sure that we're providing the same information for everyone so that everyone has that same base understanding of what it means when we start saying we're going to be billing Medicaid and doing healthcare billing. All right, I was going to say it would be helpful if my slides would advance. So today, I'm going to be covering some of the slides. Jason Young, who is with the Illinois Primary Healthcare Association, is also going to be supporting me. The Illinois Primary Healthcare Association is one of our partners in this grant. And I'm going to let Jason, do you mind introducing yourself? Because you're new to some of them, to actually all of them.
Yes, not a problem. Thank you, Rachel. Like she said, my name is Jason Young. I'm with the Illinois Primary Healthcare Association. We are the state trade association for federally qualified health centers. Personally, my background is in revenue cycle, medical billing, all things systems that go with that to make those operations work. And looking forward to presenting on the call today.
All right. So Jason and I are going to be splitting this up a little. Jason is going to cover all things billing related. I'll cover the things that are more related to community health workers because these are going to go hand in hand as we kind of delve into this new space. So our goal today is to cover these three areas. We want to explain the importance of community health worker reimbursement. What's the impact that it's going to have on sustainability and looking at service delivery? Provide a very general overview of how healthcare billing works. Like I said, we're going to be building on this series. So this very first series is providing that very basic overview. And then also start to think about what are some things that an organization may need to think about in order to start preparing and thinking about doing some billing for CHW services. So we will share this a lot. So every time you kind of hear us chatting about community health workers, we do start with the definition. Um, when I've had calls with some of you one-on-one, I know some of you actually already have community health workers on staff. Some of you have staff that are probably doing the work of a community health worker, but you're not using that title. We strongly encourage, and this is something our own organization recently went through. We have 5 community health workers on staff. We hadn't been using that exact title. We did shift. Reason being, it's going to be really beneficial with the Department of Labor. They're going to be really paying a lot of attention to this profession in the next few years, especially with a lot of Medicaid billing opportunities coming. We anticipate this workforce area growing. So if we're all using the same title and the same nomenclature for these individuals, it's going to help. The federal government is going to be paying attention and wanting to see what is going on in this workspace. So think about your own internal situation and if this might be something that makes sense for you to do. So why are we seeing this increase? Why are we seeing shifts? Why is Medicaid now starting to reimburse for community health workers? Why are we looking at ways to make community health worker positions more sustainable? Well, we're seeing shifts. First, healthcare is shifting from being volume-based, saying how many services can I bill for, whereas insurance companies are pushing back, saying no, we're not going to. We don't want to just keep providing you with money because you provided a lot of service. We want to see that there's a benefit. We want to see that people are getting healthier, not just that you're providing them with lots of services. And we know that community health workers can play a key role in achieving those outcomes. We also know that there's a lot of importance, and people are recognizing that social drivers of health, things like housing, food, transportation, social support, these are tied and have a very major factor on the impact of health outcomes. And again, community health workers are those individuals who are really positioned to address them. So we know that all of these things are contributing to this. And so because of it, we're looking for ways that we can really incorporate a community health worker into that clinical team. When you're just being funded through a grant, you don't have that same continuity. Those positions have a tendency to stop quickly when the funding runs out. When you have that sustainability built in, those positions have a tendency to maintain, and you really can, they're not considered an add-on. They really truly can become a part of that team. Finally, we also want to emphasize, that success in billing is not just about community health workers, it's about the organization as a whole. We want to make sure employers understand what infrastructure is going to be needed, and that's also looking leadership alignment, systems, workflows, what does it mean to be compliant, and what are those things that are necessary to support billing effectively. All right, Jason, I am passing it over to you.
Thanks, Rachel. So before we get any depth into the medical billing world, there are going to be some key terms that you will see and hear a lot throughout the process. To provide a few of those, first, the NPI, that is the National Provider Identifier. It is obtained from NPPES, commonly referred to as NPES. It's a division of CMS and HHS. The link for that has been provided on this slide. The second term is going to be taxonomy. So that is an identifier that is used to identify the provider's specialty, and the link for that is provided as well. And last is IMPACT. It's the Illinois Medicaid Program Advanced Cloud Technology System. This is what is used by healthcare providers wishing to bill Illinois Medicaid for services, and the system that they register into in order to be credentialed with the state Medicaid agency. Next slide, please. Thank you. So to understand the healthcare payment system, the entire healthcare billing ecosystem has a variety of components. There are various types of payment sources, such as Medicaid, which is a state program for low-income individuals. This can be traditional Medicaid, billed directly to the state Medicaid agency, or a managed care organization, which is the utilization of a private insurance entity to administer the Medicaid program for segments of the Medicaid patient population. There's also Medicare, which is a federal program for individuals over 65 or those with certain disabilities. And then commercial insurance plans, such as those obtained through employment or through private insurance purchase, such as through healthcare.gov marketplace. These include like Blue Cross Blue Shield, United Healthcare, and many, many others. So there are two payment models, but the most prominent is fee for service, which reimburses by service provided. And there are many factors within the healthcare billing ecosystem outside of this that are all critical to understand how each of these pieces work and how they work together. So knowing how to remain compliant is not only helpful to adhere to rules and regulations, but it also helps to mitigate audit risk. Next slide, please.
It takes it a minute, Jason. I promise I'm clicking.
That's okay. Thank you. So the healthcare billing process is the process by which the healthcare services are translated into claims submitted to payers for reimbursement and worked through by internal staff or external staff, depending on the route taken. Usually starts with patient registration and eligibility verification to ensure that the individual is covered by a payer such as Medicare, Medicaid, or one of the private insurers. After the services are provided, those services must be accurately documented and coded using the standardized coding system. Correct coding is critical because it determines whether a payer will consider a service reimbursable and at what rate. And once the coding is completed, the claim is generated and submitted to the payer. The payer then reviews the claim for completeness, accuracy, and compliance with its coverage policies. Claims may be paid, denied, or returned for additional information. Reimbursement timelines can vary widely, where payments may take weeks or months, and denials management is an ongoing reality in healthcare billing. Organizations must have a process in place to review denied or rejected claims, correct errors, and resubmit as appropriate. Payments are often less than the billed charges and reflect contracted or state-determined reimbursement rates. Organizations must then post the payments and reconcile them against expected reimbursement and follow up on denied or underpaid claims. This follow-up process is also known as accounts receivable management or AR management, and it's essential to maintaining financial sustainability. For community-based organizations entering healthcare billing, this process can feel complex and resource intensive. Unlike grant funding, billing revenue depends on consistent operational performance, strong documentation, and compliance with payer rules. Understanding the end-to-end billing workflow helps organizations anticipate staffing, technology, and cash flow needs. It also highlights why billing is not simply an administrative function, but a core operational capability that directly affects sustainability, compliance risk, and the organization's ability to continue serving its community. There are many challenges within the medical billing world. So the revenue cycle is not without complexities. As mentioned, claims may be denied for reasons such as missing information, incorrect codes, lack of authorization, services not covered. They can also be denied if the provider of service has not yet been fully credentialed or has missed the window for required re-credentialing with the payer source. There are also complexities of payer requirements that can lead to claims being denied by one payer, but not for another for the same service. While these challenges can present roadblocks for obtaining proper reimbursement, they are able to be navigated to reach a resolution.
All right. So now this information has come from the Department of Health and Family Services, but I want to reinforce that this is just proposed. These are proposed. This hasn't been finalized yet. The Department of Health Care and Family Services has submitted its state plan amendment, and this is what the amendment includes that would be which would identify what community health workers would be able to be reimbursed for. So it would be around services related to health promotion and education, supporting individuals with health knowledge, prevention, and chronic disease management. It's also going to be around the health system navigation, resource coordination, helping people access care and connect to community resources, and also non-clinical screening and assessments, identifying social needs, barriers to care, such as housing, food, transportation, etc. There are also going to be some billing requirements. Again, these are proposed. These could change. I want to be very clear about that. So it's not going to be a referral per se. The language they're using is that community health worker services need to be recommended. They also need to be recommended by a licensed professional. Those would include at this point a physician, advanced practice nurse, a physician assistant, clinical psychologist, clinical social worker, or dentist. These services must be provided to a Medicaid member. So if you have someone who is experiencing homelessness, they are not on Medicaid yet, those services would not be billable until that person reached that point of being a Medicaid member. So there are some gaps in areas that we know will be, challenging. They must be medically necessary. We're still waiting to get clarification on what that will include. We also believe there's going to be service limits. So, for example, a community health worker will only be able to provide services for up to 2 hours per day, and there will be a maximum of 12 hours per calendar month. We do know it appears that they're going to allow for service delivery to be individual, but also in groups. And they had this broken out. It was one individual, and then I think it was 2 to 3, and then like 5 to 8. So, and the payment would be different based on that as well. So some of the things that we hear, some of the things that we want to just make sure we're addressing head on. There are some misconceptions that we hear in this space. Great. Once HFS has this finalized, we can start billing next month. No, there's other things that are going to need to take place before that can even begin. That's what we're going to keep building upon in these webinars to really help prepare you for what that's going to look like. Some of this we can't even begin yet because they won't allow us to begin until this has been released. Billing will automatically create profits. Yeah, revenue depends on volume. How much are you billing? What are those rates? What are the other costs associated that you're having to incur in order to do the billing? Documentation. This is going to be huge, and we are going to spend significant time on this. Documentation is essential to making sure that we're able to submit payments and have those payments approved and then reimbursed. This is very different than any type of documentation these community health workers have probably ever done. If they've only ever been supported through a grant, what that type of reporting would have been and what that would have looked like, or what documentation you may be, currently gathering may look very, very different than what is going to be required by Medicaid. Another area that we just really want to stress and mention, just because this is a service related to community health workers should not necessarily be doing all the administrative work themselves. We want community health workers to still be doing those important functions that you hired them to do. It takes more people than a community health worker to be supporting the work that's going to be necessary to be able to bill for them.
So some of the barriers to implementing a billing process for community health workers are going to be the workflows. Workflows are critical. Organizations struggle with unclear and consistent processes, especially across program, clinical, and billing teams. And without a defined workflow, things like documentation, referrals, managing denied claims, those can break down easily. Um, Another piece is the systems and the EHRs. There are um, major challenges involved with ensuring you have the right systems in place. If your technology doesn't support documentation, coding, or billing workflows, staff might end up using workarounds that increase errors and administrative burden. Technology and infrastructure play a critical role in billing in healthcare successfully. At a minimum, organizations need a system for documenting the services in a consistent, retrievable, and a secure way. This might be an electronic health record, care management platform, or some other structured documentation system. Whatever the tool is, it must be supported. It must support the required data elements and protect sensitive patient information in compliance with HIPAA and other privacy laws. Billing and claims management systems are also essential. These systems generate the claims, track their status, and support follow-up on denials or delayed payments. Some CBOs choose to outsource billing to a third-party vendor, while others build internal capacity. Each approach has trade-offs related to cost, control, and learning curve. The infrastructure also includes data reporting and analytics capabilities. Payers often require regular reporting on service utilization, outcomes, quality measures. And internally, organizations need data to understand financial performance, monitor their productivity, and assess return on investment. So investing in the right technology early can prevent downstream challenges and reduce staff burden, but the technology must be matched with training and clear workflows to be effective. There are different billing options, independent billing. This would require to have your own billing and documentation platform, but this can be costly for smaller organizations. In the past, some of the large EHRs that I've worked with, I've seen product licensure for one provider cost as much as $15,000 a year. I mean, they are very costly systems to implement, and they're very technology heavy. An existing Medicaid enrolled provider, those submit claims on your behalf and then reimburse the provider based on a subcontract. There are third-party billing options for outsourcing billing to a third-party organization that can submit claims and might have that technology in place on their end to help assist with those things. And then something that other states have utilized or that is being explored in Illinois is a community care hub. So this is a community-focused organization that supports CBOs who provide health-related social needs services in an area or a region. And this model can allow for that same level of partnership for the technology piece as well. And as we mentioned on the last slide, some CBOs choose to outsource their billing, while others build internal processes through purchasing licensure to build existing billing and documentation platforms. Like I just mentioned, the state of Illinois has released recently a notice of funding opportunity to explore options for the creation of a community care hub that would act as a resource for CBOs for documentation, billing, and referral management. And as we learn more, additional webinar series and information will be available to discuss this. So some other challenges around CHW billing would be the financial planning. Organizations can sometimes assume billing will immediately generate revenue, as Rachel said, but that is a misconception because without the financial modeling, understanding costs, reimbursement rates, and volume, it can be difficult to sustain. So another key issue aside from that would be the referral infrastructure. So billing depends on having a steady flow of eligible billable services. Without clear referral pathways from providers or care teams, CHWs may not have consistent opportunities to deliver billable services. And finally, the role clarity is essential. If staff don't clearly understand who's responsible for documentation, supervision, billing, and oversight, it can create confusion and gaps that affect both compliance and reimbursement. So overall, these challenges are very common, but they're also addressable with the right planning, structure, and leadership support.
Which is why we're doing this webinar series first.
Yes. So pursuing healthcare billing for CHW services obviously comes with some real challenges. Payer rules can be complex, inconsistent, subject to change, require ongoing monitoring and adaptation. There's a lot of administrative burden, and this may fall disproportionately on smaller organizations with fewer resources, potentially diverting attention from direct community engagement. There's also variability across states and payers and how CHW services are defined and reimbursed. What is billable in one context may not be billable in another, complicating multi-state operations or partnerships. Equity considerations are critical as well. Organizations must ensure that billing requirements do not exclude the most marginalized community members or pressure CHWs to prioritize billing activities over community identified needs. Strategically, organizations benefit from phased approaches, partnerships with healthcare providers, and participation in learning collaboratives or technical assistance programs. Advocacy remains important to shape reimbursed models that reflect the full value of CHW work. By approaching billing thoughtfully, CBOs can leverage reimbursement as a tool to strengthen rather than compromise their mission.
All right. So some of these workforce and training requirements, these are things that have been built into the project as well. So we are going to be providing this support in addition to the billing support and some of the items that Jason just referenced. So it's going to be really important that community health workers are supported. We will be, finding ways to help them understand how will they document the work that they're doing so that it will meet the payer requirements. It's also often requires training on what information to capture, how to write those notes, and why documentation matters. And this is going to be ongoing for them. And also, it's going to be important that their supervisors understand this. So we have that community health worker collaborative that's been developed in Lake County and that supervisor collaborative. And we will be working on these components, spending a lot of time on them. We also want to make sure that we are utilizing staff appropriately and balancing those workloads. If organizations do plan to do their own billing, it's going to be important to understand and identify who will be doing different components of it. We also want to make sure that roles are clear so we are preventing burnout and hopefully preventing errors. And it's going to be really important that we invest not just in our community health workers, but in making sure they receive the training. Supervisors understand what's necessary in order to bill. So we continue to have that staff morale, confidence, and retention. So what really matters? When we talk about billing, what is it? What's behind all of this? So it's community health workers need to be meaningfully integrated into the care teams. We don't want them just to be seen as an add-on. So they need to be embedded and effectively incorporated, and those rules need to be clearly defined. The billing requires systems, workflows, leadership for support, and coordination across those teams. Without that infrastructure, and there are different options that are available because Jason shared them, even strong programs can face challenges with sustainability and compliance. And documentation isn't just a requirement. It's what really tells the story of the work that's being done, and it needs to clearly demonstrate the value of a community health worker services and support billing claims. Community health workers are effective because of the trust they build. As organizations move towards billing, it's important not to lose that connection or shift too far away. This is a concern. We're hearing this across the state. People are concerned and worried, rightfully so, that as people begin to bill for services, we forget what it is to be a community health worker. And some of those services that are maybe not billable kind of get missed or ignored. So it's going to be really, really important to reinforce and continue to align with your mission to ensure that everything is being addressed through your community health workers that can be. And the goal of billing isn't just short-term revenue. It's really creating a model that allows community health worker programs to grow, stabilize, and continue to serve communities over time. So we have another webinar scheduled for next week. No, the 29th. I think that's a Monday. This one is really going to start delving more into understanding what are your community health worker roles and will they be billable? So it's really spending more time understanding what that might look like. Does CHW integration align with your organization mission? Are there things your organization may have to think about differently? Are there conversations you may have to have with your board to see, does this make sense for your organization? We also plan to have additional webinars, and some of the topics that we plan to cover are going to be things like, Jason mentioned that organizations are going to need an MPI number. They're going to need to register an impact. For someone who has never done that, that's overwhelming. So when the time makes sense for you, we will make sure we walk you through that process and help you understand what that will look like. Again, we've mentioned multiple times the need for documentation because that's tied to being compliant and tied to getting reimbursed. So we'll be offering something around that space. Also looking at finance modeling. How can you start to get an idea and do some revenue forecasting based on your return on investment? Jason's actually helped us create a model, a formula where we can actually start to plug in. If you have someone on staff, you anticipate them doing this number of services, we anticipate this amount that they'll be reimbursed for. What could that potentially look like for your organization? So you can start doing some of that forecasting yourself. We still believe because there are a significant number of services that are not going to be billable, braided funding is still going to be something that's necessary for community health workers, not just in Lake County, but throughout the state. We have an idea of the different pathways that are going to be available for community health workers. We actually shared it at the Community Health Worker Collaborative meeting earlier this week. Again, those are proposed. We know that things may change before they're released. We just wanted to start at least giving people an idea of what we anticipate so they can start to maybe think about who do I need to reach out to if I'm going to need a letter, sharing what history I've had in this space and how many hours I may have done that. So we're just providing this information so people can start to get prepared and think about what they may need. Looking at populations. So one of the things we actually have a tool that helps to identify, are there services that maybe aren't being addressed in Lake County that might be services that are needed? And if so, how could that look for your organization? Does that make sense for you to think about the populations you're serving and how could those align with maybe some of those reimbursable activities? And then it's going to be so incredibly important to develop partnerships. How do we work together so we're creating really strong referral pathways? Whoops, I went backwards and not forwards. But we did want to open it up for questions. I've also included my email. So if you do have any questions and you don't want to ask them here in this session, you are welcome to email me. I'm also going to check the chat. So if you'd prefer to type it versus you can come off your mute and speak. I see, Jackie, you had a question. At this point, it appears that the rate is going to be around the $60 an hour mark. Do you remember the exact rate, Jason? Is it like $63 or?
Let me pull my modeling spreadsheet up real quick. I can provide a little bit more detail as well on that.
All right, I'm going into the chat now. It's really hard for me to multitask, so I have to
I did
do
provide my
one.
email in the chat as well. If anybody has any billing related questions, I'm more than happy to answer what I can. So it looks like for the individual patient education from a CHW per 15 minutes is $16.39. So what does that work out to be? So $65.56 for an hour of services one-on-one from the CHW. And then
So
the group amount is $5.12. So for an hour, that is $20.48. But that is billable for each member in the group.
so if you had 6 people participating, you'd take that number and multiply it by 6.
Yeah. Yep.
And they also will allow certain services will be billable at a rate of 15-minute increments and 30. So it'll be, like I said, that we believe that those will be, that's what they're submitting. So we'll have to see what gets approved in that state amendment. So Vicky, along with medical necessity, can HFS clarify how these services will be assessed or determined in IMCAN? Some EHR systems have this custom built in, so we need to make changes on this end as well. Jason, do you have
I think Tracy had answered that in the chat actually, so that they're
Oh, thank you. I didn't go far enough
yeah.
down.
That's something that has been requested from HFS is to get some more clarity on the
Yes,
definition of that medical necessity. So
thank you. All right. Something I anticipate when working collaboratively among CBOs, there will need to be an infrastructure to support how we bill as an ecosystem of utilizing care system and universal tracking. So that is something, if a community care hub is utilized, that is something we're aware of that we hope will be incorporated. Because there's also the concern that, yes, you can only bill 12 hours a month for a community health worker. If you have multiple organizations providing community health worker supports, how do we ensure that those organizations are able to be compensated for the services and not going over those 12 hours? So that is something a community care hub would be helping to manage. The term recommended by physician, etc. Who is recommended? Community health worker or care receiver? So a lot of times if someone's getting released from the hospital, it may be, that it's saying recommended that a community health worker provide these services. Then that individual, the case manager in the hospital, then would be making those referrals out, and it's going to depend on what types of services that individual needs. Is it support with housing? Is it support with food assistance? So it would go not to the individual, but to that organization who provides those types of services. But again, if you have a community care hub, that care hub would be helping to do those closed loop referrals because there is concern. There's a lot of drop off. We want to make sure that those referrals actually happen, that individual receives that support. And the only way you can really truly track that is if you have a hub type model. Jason, did you want to add anything to that?
no, that was perfectly stated. Yeah.
Okay, let's see. Oh, we addressed the commonly hourly rate. I am going to go to the next slide. As we're just kind of chatting, if you could complete this post-webinar survey as you're participating in this project with us, we are trying to make sure that we're gathering as much data, making sure that what we're providing is helpful. So as much feedback as possible, and that's what these surveys are helping us to do. Oh, have the hubs been established for Lake County? So Angelina, there is a NOFO that just recently came up by the state about a week ago that is developing these components. So the community care hub concept has been broken out into 3 NOFOs. One is a referral system. The state has identified ICARS, which is going to be providing that component. They're in the procurement stage now. One of them is the Social Health Care Network. So an organization that Jason and I, along with the Illinois Public Health Association, we're actively going to be working on submitting something towards that one. And then there's going to be another NOFO coming out that's billing related. So they're taking all these components of a hub and we're waiting to kind of see how it develops. So our goal is that Lake County would be able to participate in whatever hub is developed by the state. There will be other options as well, but we're just kind of monitoring everything as it's happening. Does that help? Does anyone have any other questions? Like I said, we are going to, the next webinar that we're offering is June 29th. We did send out meeting invites for it. We will be recording all of these calls, and I will share the recording with you or with those who weren't able to attend. And we're going to be doing that for all of them because we realize the time that we scheduled may not work for everyone, but we want to make sure you have access to this information. Oh, let's see. Can you please? Yes, we can share the slides too. Thank you, Vicky. I meant to do that, but I'm glad you prompted me and reminded me. And Angelina, yes, as we are working on this, we will continue. We'll keep everyone in this project involved. We want to make sure that we are kind of, as we're sharing the information, even back with the state, we're doing so with the perspective of how can this support and help Lake County. So there will be a lot of communication, and at this point, where it's kind of in a wait and see. Um, we'll just kind of have to see how this develops for the state. There's just a lot of moving parts, as you can imagine.
Thank you so much, Rachel.